Good afternoon. I would first like to thank the organizing committee for giving me an opportunity to present this talk, non-radiographic axial spondyloarthritis, new name to an old disease. I, I am sad I'm not there with you today in Lahore to present this talk. As you know, international travel has been a little hassle this year, but I'm more than happy to present it virtually to you, and I hope you're all having a good meeting. These are my disclosures, and the objectives of the talk today are to discuss challenging about this concept of non-radiographic axial SPA, and also to go over how to make this diagnosis, and then finally touch upon the treatment options and some evolving treatments for non-radiographic axial SPA. I'm going to start with the history of how this term non-radiographic evolved. The term ankylosing spondylitis that we are all familiar with was coined in early 1904. Then in 1930, it was recognized that patients with ankylosing spondylitis have an association with this inflammation in SI joints, and this was seen on X-rays. Then in 1961 and 1966, the certain criteria were put together to classify ankylosing spondylitis, and both these criteria included radiographic sacroiliitis, which were then modified in New York in 1984. However, in early 1980s, there were some family studies done on patients with ankylosing spondylitis by one of our own, Dr. Khan, and he recognized with his team that some of these patients had family members that were HLA-B27 positive, HLA-B27 positive probands, had symptoms suggestive of inflammatory back pain, stiffness, fatigue, but did not have changes on the X-rays. So this information kind of, made them think that these criteria that included radiographic sacroiliitis may be limiting, and this disease may be beyond these criteria. And it was in 2009 when the ESA's classification criteria were developed that this term was formally recognized as non-radiographic axial spondyloarthritis. So based on the 2009 ESA's classification criteria, patients that have chronic back pain that starts before the age of 45 years, and these patients are divided into two arms, an imaging arm and a clinical arm, and patients in the imaging arm had to have sacroiliitis either on an X-ray or on an MRI of the SI joints. So the presence of definitive sacroiliitis is needed for the definition of radiographic sacroiliitis, but those patients that do not have radiographic sacroiliitis, they may have sacroiliitis on an MRI and have one clinical feature of spondyloarthritis, or those patients that are HLA-B27 positive and have two features of spondyloarthritis were classified as having non-radiographic axial spondyloarthritis. You just remember that these are classification criteria and not the diagnostic criteria. The differentiation between non-radiographic and radiographic axial spondyloarthritis may be important for clinical research, but for us in clinical practice, I don't think we need to differentiate it since they belong to the same spectrum of axial spondyloarthritis. One may be at earlier phase and another may be the later phase of the disease, but they belong within the same heterogeneous spectrum of axial spondyloarthritis. The epidemiology of non-radiographic axial SPA is not well established yet because the disease is very heterogeneous. This was not incorporated in the ICD-9 and ICD-11 codes up till recently. And so based on one study, the prevalence in the United States is about 0.35, which is roughly similar to the prevalence of ankylosing spondylitis, which is 0.35 to 0.5. A large registry in the United States called Corona Registry, which is now also called Corvitas Registry, has shown that non-radiographic axial SPA is more common in females compared to males, and this was also shown in the PRO-SPA study, which was a study on of patients with axial SPA in North America. So what is the role of imaging? How does imaging help us in making this diagnosis? So as rheumatologists, we rely on imaging a lot. So the gold standard for making the diagnosis of ankylosing spondylitis is to get an X-ray of the pelvis. And when we get an X-ray of the pelvis, we are looking for erosions in the sacroiliac joint, sclerosis, or ankylosis of the joint. So we have 4 grades of sacroiliitis: grade 1, grade 2, grade 3, and grade 4. So grade 3 and grade 4 is no-brainer. The joint here is partially ankylosed, it's completely ankylosed here. Once we see this, this is an advanced stage of the disease, and it's very easy to identify this. However, grade 1 and grade 2 sacroiliitis are actually where we run into trouble because we're not quite sure. The findings are equivocal. We may not be sure whether the patient has sacroiliitis or not. And in those patients is where we rely on getting an MRI of the SI joints. So this is look at this X-ray of the pelvis here. On this side, left side, the joint, SI joint looks fine. On the right side, there may be questionable, fuzziness of the margins, which we may call grade 1 or grade 2. And these are the patients who we say have non-radiographic axial SpA. We do not see definite radiographic changes on the X-ray. So when we order the MRI of the SI joint, one needs to order a non-contrast MRI with 2 sequences: a T1, which is a fat enhancing sequence, you see fat in the subcutaneous tissue, and a STIR, or a fat suppressed sequence. But the reason for that is this bone marrow edema on STIR image is a hyper intense signal, and on a T1, it's a hypo intense signal. So we are basically looking for bone marrow edema, and on a STIR image, suggesting that there is osteitis or inflammation in the SI joints. In 2016, ASAS put forward a definition for positive MRI in patients that have active sacroiliitis, and they said that there should be a hyperintense signal on a STIR image and usually a hypointense signal on a T1 image, but MRI should be highly suggestive of spondyloarthritis based on the size of the edema, large area of edema, location of the edema. It should be adjacent to the SI joints. It should be intense, and there may be concomitant structural lesions on T1 scan. Other inflammatory changes like synovitis, like capsulitis, alone without bone marrow edema do not constitute positive MRI. Similarly, structural damage like erosions and sclerosis alone without edema does not constitute active sacroiliitis. MRI definition of active sacroiliitis: patient may have damage, but in order for it to have active disease, one needs to have bone marrow edema on the MRI of the SI joints. This was a recent paper that was published last year by the ASAS MRI group, and they wanted to look how can we increase the predictivity of this MRI for making the clinical diagnosis of axial SpA. And they came up, they said if the bone marrow edema is present in at least 3 or more consecutive slices, that increases the likelihood that this patient may have non-radiographic axial SpA. Similarly, if you see other lesions or structural changes in at least in 4 SI joint quadrants, and the bone marrow edema has to be present at least in one of these quadrants to increase the likelihood of axial SpA. However, is MRI enough to make this diagnosis? The sensitivity of the MRI of the SI joints is very high, but the specificity is not that good. Several studies have shown that patients, like 30 to 35% of healthy recreational runners, 41% of elite ice hockey players meet the ASAS definition for sacroiliitis. Postpartum women with back pain have also been shown to meet the definition of active sacroiliitis. So the study is very sensitive. The MRI is very sensitive, but not very specific for making the diagnosis. So one needs to remember that 2 white spots on MRI is not specific, and it can be seen in healthy volunteers and in patients with degenerative disease of SI joint and spine. This was a study looking at diagnostic utility of MRI to differentiate patients with axial SpA from non-specific back pain. About 187 subjects were included in this study with an age of less than 45 years. 75 of them had established AS, 27 had non-radiographic axial SpA, 26 with non-specific back pain, and 59 healthy controls. About 7% of healthy controls had bone marrow edema suggestive of fulfilling the ASAS definition, suggestive of non-radiographic axial SpA fulfilling the ASAS definition. And 23% of patients with non-specific back pain. So telling you that this, it's not very specific to non-radiographic. So when interpreting the results of an MRI of the SI joint, please keep in mind the clinical picture of the patient. Patient needs to have other SpA features along with this in order to make this diagnosis. Are there any features that increase the specificity of the MRI? Obviously, if there are erosions in the joints, backfill and ankylosis has been shown to have the highest specificity for axial spondyloarthritis, radiographic axial spondyloarthritis, and on an MRI. If you see backfill is basically what you see is a fatty change within the SI joint, and ankylosis obviously when the joint is completely fused. Higher cutoff for bone marrow edema and fat lesion increases the likelihood that the patient has non-radiographic axial SpA. Low-dose CT is now being assessed for letting us know about structural damage. It could be a viable alternative to conventional X-ray. It does not expose patients to much radiation. However, it's only still used in research protocols and not yet available clinically. Are there any laboratory tests that help us? We don't have any specific biomarkers to make this diagnosis, like we have rheumatoid factor, anti-CCP antibodies in rheumatoid arthritis. We do not have any biomarkers. HLA-B27 may help in making the diagnosis, but negative HLA-B27 does not rule out that the patient cannot have axial disease. Some minorities, women, tend to be HLA-B27 negative. Similarly, acute phase reactants like CRP and ESR are not always elevated in these patients. Only 60% of patients with axial SpA may have elevated CRP. Remember, but elevated CRP and ESR are broad prognostic factors. Those patients that do have elevated CRP, they're more likely to have structural damage. And this was a diagnostic algorithm that was proposed by ASAS for diagnosing or exclusion of axial spondyloarthritis. So the stem remains the same. Patient has to have chronic back pain lasting for more than 3 months with an age of onset less than 45 years. This back pain has to start early on. And other causes of back pain, like mechanical back pain, fibromyalgia, first need to be ruled out. So the first test that needs to be ordered is an X-ray of the pelvis, looking for radiographic sacroiliitis. If you see on an X-ray that there is sacroiliitis, there are erosions, there is sclerosis, then we can stop there. However, those patients that do not have definite radiographic sacroiliitis, who we call non-radiographic axial SpA, they got divided into 3 groups. Those that have 4 or more features of spondyloarthritis, they could have inflammatory back pain with psoriasis, acute anterior uveitis, family history of AS, good response to steroids. They said if there is a compelling history with these patients, there may nothing, you don't need to do much. If there is no compelling history, check HLA-B27, and if it's HLA-B27 positive, you can stop there. Patients with 2 to 3 spondyloarthritis feature, and order an HLA-B27, and if HLA-B27 is not positive, they are HLA-B27 negative, then get an MRI of the SI joints. However, patients that have only 0 to 1 features of spondyloarthritis, whether they are HLA-B27 positive or HLA-B27 negative, MRI of the SI joints is recommended, because these are the patients where you want to make sure that there is active sacroiliitis. And I often get a question from some of my colleagues asking me, what do we do in patients who have just inflammatory back pain, but we ordered an MRI of the SI joints and that is normal, and they're HLA-B27 negative. In those patients, I often tell them you could put them on NSAIDs and watch them. They may evolve over the time. So do all patients with non-radiographic axial SpA progress to radiographic axial SpA? This is a question often asked by our patients. Am I going to fuse my spine? What are the chances of me having structural damage? So the lifetime risk of progression is about 50%. This is what I tell my patients. There are several studies that have looked at it, and and they have found that the rate of progression is about 5 to 12% over a period of 2 years. And there are certain predictors of progression that have been identified in various studies, like patients that have elevated ESR and CRP. These are modifiable risk factors. Patients which have large amounts of edema on an MRI of the SI joints, high spark scores, another modifiable factor. Once we treat them, we can reverse it. Smoking is also a risk factor for structural damage. It has been shown to be in some studies, so I advise patients to quit smoking. Other non-modifiable risk factors are male sex and HLA-B27 positivity. So this is the information I give to my patients. If a patient has a family member that is HLA-B27 positive and has ankylosing spondylitis, and this patient who now comes to us with back pain with positive HLA-B27, there is about 20 to 25% this patient may also have axial spondyloarthritis. Are there similarities and differences between the two, even though they belong to the same spectrum of axial spondyloarthritis? No major differences, except, as I mentioned earlier, females tend to have non-radiographic axial SpA. Elevated CRP is more commonly seen in radiographic axial SpA in AS, and obviously, the metrology index is high in patients with radiographic damage since they have structural damage. Despite non-radiographic axial SpA having shorter disease duration, less burden of structural damage, the burden of disease is similar between the two. The pain scores, disease activity scores are very high in both non-radiographic and radiographic axial SpA. The functional index is impaired in both of them. So one needs to keep that in mind when treating these patients, that non-radiographic axial disease is not less severe as compared to AS. The disease burden is similar and they need to be treated in similar manner or equally. However, women have a unique presentation and burden of disease. They often present most with enthesitis, heel pain, plantar fasciitis, chest wall pain, trochanteric bursitis. They may have peripheral arthritis, predominantly involving the lower extremities, knee swelling. They often get diagnosed as fibromyalgia and psychosomatic disorder. Their inflammatory markers are lower compared to men, and this results in more diagnostic delay in women with poor quality of life. So we previously thought this was predominantly a disease of men, but now with this understanding of non-radiographic axial SpA, we have realized that it is equally common in women, if not more common than men. At present, we have three classes of medications available for treatment of non-radiographic axial SpA. We have TNF-alpha inhibitors, we have IL-17A inhibitors, and we have Janus kinase inhibitors. We do not have any head-to-head studies showing us one TNF inhibitor is better than the other. This illustration here, is for this figure here is for the purpose of illustration. And what we see here is that adalimumab, certolizumab, etanercept, golimumab are equally efficacious in patients with non-radiographic axial SpA. In the United States, only certolizumab is approved for non-radiographic, but I have been prescribing all the other TNF inhibitors in my patients since they're equally efficacious in non-radiographic axial SpA. And this is no-brainer since it is the same disease as radiographic axial SpA. So these TNF inhibitors worked in radiographic axial SpA, so they have to work in non-radiographic axial SpA too. Are the responses to TNF inhibitors similar in radiographic and non-radiographic axial SpA? There is one study, the certolizumab study, which included patients both with AS and non-radiographic axial SpA. And if you look at the ASAS-40 response at week 24, it was 47.7% response in AS patients compared to 56.5% in non-radiographic at week 24, not a big difference. And the dose that was used here was certolizumab 200 milligram every 2 weekly. So TNF inhibitors, one can presume from this, are equally efficacious in radiographic and non-radiographic axial SpA. This is a very important study I would like to present here. This was an etanercept in patients that were suspected to have non-radiographic axial SpA. They had to have inflammatory back pain, or they could be HLA-B27 positive with one feature of SpA, or HLA-B27 negative with 2 features of SpA. High disease activity based on patient-reported outcome BAS-DI, and insufficient response to at least 2 NSAIDs. Only 23% of these patients in the study had a positive MRI, and 13% had elevated CRP. So these patients were treated with etanercept, and half were treated with placebo up to week 16. The primary endpoint was ASAS-20 response, and these were other secondary endpoints. And the primary endpoint ASAS-20 response was not reached at week 16. There was no difference between patients taking etanercept or taking placebo. The mean BAS-DI scores decreased equally between the etanercept and the placebo group. Hence, it was shown that in these patients suspected with non-radiographic axial SpA with high disease activity as measured by BASDI, but that did not have a positive finding on an MRI or an elevated CRP, treatment with etanercept is not effective. With these findings in mind, this year, Assas and Euler, they updated their recommendations for treatment of patients with axial SpA. 2022 recommendations, they were presented at Euler. So these, based on those recommendations, patients have to have a rheumatologist diagnosis of axial SpA. They have to have elevated CRP or a positive MRI, meaning sacroiliitis or an MRI, or radiographic sacroiliitis, and have to have failed at least 2 NSAIDs, and they, with high disease activity, defined as an ASDAS score greater than 2.1. And those are the patients that need to be started on biologic therapy. They also updated that, one of the recommendations. They said once patients fail non-steroidal anti-inflammatory drugs, you could start on a TNF inhibitor, IL-17 inhibitor, or a JAK1 inhibitor. They did not give preference of one over the other. However, they made conditional recommendations that patients with history of recurrent uveitis or active inflammatory bowel disease, they prefer monoclonal antibody, TNF inhibitor antibodies, and those patients that have psoriasis, they prefer IL-17 inhibitors in those patients. And so IL-17 inhibitors have been shown to be efficacious in non-radiographic axial SpA. Secukinumab, has been tested in PREVENT study. There were 2 doses used. The loading dose, which is the dark blue, and the light blue is the secukinumab non-loading. There was not a big difference between loading or a non-loading dose, both at week 16 and week 52. So you could choose whichever way you want to use secukinumab in patients with non-radiographic axial SpA. Similarly, ixekizumab has also been tested in COAST-X study, where 2 doses were tested for ixekizumab, 80 milligrams every 2 weeks and every 4 weeks. It is approved every 4 weeks. So these are the results from this light green here, and is efficacious in non-radiographic axial SpA. Upadacitinib, which is a selective Janus kinase 1 inhibitor, has also been tested in non-radiographic axial SpA, with the patients were randomized either to placebo or upadacitinib up till week 15, and thereafter they continued on upadacitinib up till week 104. The primary endpoint of ASAS-40 was reached at week 14, 45% versus 23%, response with upadacitinib. Also, all other secondary endpoints were reached. In terms of adverse events, there were no serious adverse events. Herpes zoster was seen in 2 patients with upadacitinib. Neutropenia was seen in 5 patients, and no flares of inflammatory bowel disease or psoriasis. There was 1 patient that had flare of uveitis in the upadacitinib arm. Tofacitinib, which has been approved for the treatment of ankylosing spondylitis, has been shown to be efficacious with AS, and I will talk about it later, and can also be used in patients with non-radiographic, even though we don't have studies of tofacitinib published yet in non-radiographic axial SpA. What are the emerging treatments for non-radiographic axial SpA? Bimekizumab, it's a monoclonal antibody that is a dual inhibitor of IL-17F along with IL-17A. These were data presented at the Euler meeting. This abstract showed that bimekizumab, as compared to placebo, was found to be efficacious in patients with non-radiographic axial SpA. At week 16, 47.7% of patients with bimekizumab attained ASAS-40 response, compared to only 21.4% with the placebo. And the response rates of other secondary endpoints were also met. With regards to safety, it was overall safe. There were not serious adverse events. The most common, side effects were upper respiratory tract infections. Oral candidiasis was seen in more patients on bimekizumab than on the placebo arm, and this candidiasis was not mild to moderate, not any disseminated or severe candidiasis. So this question is often asked by our patients: can we reduce therapy once they attain remission? Few studies have evaluated this in non-radiographic axial SpA. Re-embark, ability co-optimize those patients that achieved remission, which was or inactive disease status, which was defined as ASDAS score of less than 1.3. And in these patients, half of them continued on the medication, other half the medication was stopped. And what was found that those patients that stopped the medication, the flare rates were higher compared to the patients that continued the medications, But keep in mind, a large proportion of patients that stopped the medications also remained flare-free. Certolizumab was looked into co-optimized study where they used two doses, 200 milligrams every 4 weeks and 400 milligrams every 4 weeks. They reduced the dose of certolizumab from 200 every 2 weeks to 200 every 4 weeks. And they found that 200 every 4 weeks was as, efficacious as 400 milligrams once a month for preventing flares. So giving us an option that we could reduce the dose in patients that have achieved remission. So the take-home points are non-radiographic is not a separate disease, but a spectrum of axial SpA. Early recognition and treatment is critical. Radiographic progression is variable in non-radiographic. Availability of MRI has revolutionized, but the findings have to be interpreted in the context of entire clinical picture. And we have 3 classes of medications now available for treatment of this disease. And thank you for your attention, and I will be available for any questions.